Now let us discuss about anemia. Anemia, we know anemia is a medical condition that is characterized by deficiency in the number and quality of the red blood cells or the hemoglobin in the blood. The hemoglobin, we know HB, it's a protein in the red blood cells that carries oxygen from lungs to the rest of the body. Now anemia can result from various underlying causes, and it reduces the ability of blood to carry oxygen to tissues throughout the body. Now we can classify the anemia into pathophysiological mechanism or morphological characters. The first is the pathophysiological classification of anemia. So the first is anemia due to the blood loss. So that can occur suddenly due to the significant blood loss from the traumatic injury, or the blood loss, it can occur through the acute post hemorrhagic anemia. That can occur due to the blood loss such as from the traumatic injury or surgery, or anemia of chronic blood loss that develops over time, like GIT bleeding or heavy menstruational periods. Other could be anemia due to impaired red cell function, like there could be cytoplasmic maturation defect, like in case of if there is a deficient heme synthesis, so that would lead to iron deficiency anemia, or it could be deficient globin synthesis that results in thalassemia. Now there could be nuclear maturation defect, like vitamin B12 or folic acid deficiency that can cause megaloblastic anemia, or there could be hemopoietic stem cell proliferation and differentiation abnormalities, like in case of aplastic anemia, so where it is a condition where bone marrow, it will fail to produce sufficient red blood cells. Apart from that, bone marrow failure can occur due to the systemic diseases. Chronic diseases can suppress the bone marrow function. Anemia in the renal diseases, like in case of kidney, fail to produce adequate erythropoietin hormone that leads to decrease in the red cell production. Other anemia could be due to the endocrine and nutritional deficiency. Anemia in the liver disease, liver dysfunction can also affect the RBC cell production. Leukemia, lymphoma, these are the cells that can invade the bone marrow. Multiple sclerosis, congenital anemia could be sideroblastic anemia, a genetic defect in which iron is incorporated into the hemoglobin. Anemia due to increased due to increased red RBC destruction. That could be hemolytic anemia. Now that could be either intracorpuscular, that means they are hereditary, and they affect the red cell membrane, enzymes or hemoglobin, or they could be extracorpuscular through the acquired conditions like red cell destruction. The second classification is about morphological classification. Like is the first is a microcytic hypochromic anemia. That condition, that here you will see reduced MCV, MCH and reduced MCHC. So example is iron deficiency anemia, sideroblastic anemia, thalassemia. So remember, microcytic hypochromic anemia, it is seen in SIT, that is sideroblastic, iron deficiency anemia and thalassemia. Other characteristic is normocytic, normochromic anemia. Here you will see normal MCV, MCH and MCHC. That would be seen in acute blood loss, hemolytic anemia, bone marrow failure, or anemia of chronic disorder. So remember that. Other is raised MCV. So that could be, example could be megaloblastic anemia due to deficiency of vitamin B12 or folic acid. The anemia of blood loss, it is categorized based on rate on which blood is lost. So when blood loss occurs suddenly, the following physiological responses and laboratory findings you would see. First of all, there would be reduction in the blood volume that can result in shock like situation. That would be the physiological response. So if the patient, he survives the initial threat, then the interstitial fluid, remember the interstitial fluid would shift into the intravascular compartments in order to compensate for the blood loss. So that result in heme dilution, and that result in decreased hematocrit. Apart from that, you will see the hypoxia. That means there would be reduced oxygen level in the tissues. That would stimulate the production of erythropoietin. that is a hormone that produces increased that promotes increased red blood cell production in the bone marrow. So here the red blood cells, they are normal in size and hemoglobin content, but their number is reduced. So you would see is normocytic normochromic anemia. Apart from that, there would be lower hematocrit value, increase in the reticulocytes count. So that indicate that there is accelerated increase erythropoiesis in the bone marrow. In case of the chronic blood loss, the blood loss occurs gradually, allowing the body to compensate for some extent until the iron stores they are depleted. So when the loss exceeds the rate of production and iron reserves are exhausted, the iron deficiency anemia would occur. Now, in case of what would be in the chronic blood loss, you would see is hypochromic microcytic anemia. That means that the RBC cells, they would be smaller in size and have a reduced hemoglobin content. The hypochromic anemia is primarily caused by iron deficiency anemia, but it can occur due to the other conditions. Now, let us discuss the causes of hypochromic anemia. The first is the iron deficiency anemia. Now, iron deficiency anemia, we note that the most common cause of anemia worldwide is the iron deficiency anemia. So, iron deficiency anemia would impair the hemoglobin. The iron deficiency anemia would impair the hemoglobin synthesis that lead to microcytic hypochromic anemia. The most common nutritional deficiency worldwide it's the iron deficiency anemia. Now, what are the sources and losses of iron? The iron from food such as leafy vegetables, beans, meats, liver, they are the good sources. Daily iron losses can occur in adult male and non-menstruating female. About daily losses of 1 milligram of iron is lost, but menstruating women, they lost additional 0.5 to 1 milligram of the iron daily. Now, iron, remember, it is absorbed mainly in the duodenum and proximal jejunum. Remember the heme iron, it is that is from the animal sources, it is better absorbed than the non-heme iron that have a plant source. Now, what are the factors that enhances the non-heme iron absorption? Vitamin C, citric acid, amino acid, sugars, HCl, and gastric secretions. What are the inhibitor of non-heme iron absorption? Is the antacids, milk, pancreatic secretions, phytates, EDTA, and the tannic acid. So that is important for your entrance exam point of view. Now, the iron, we know it's found in plasma, it is bound to transferrin. That is a beta globin synthesized in the liver. The transferrin, it transport the iron to developing erythrocyte cells. So there are many transferrin receptors that are present on many tissues. So this transferrin, it is recycled after iron is relieved. What is the storage form of iron? Remember, it's the ferritin and hemosiderin. So remember that the ferritin and hemosiderin, they are in the mononuclear phagocyte cells of liver. They store. Now the body cannot regulate iron content by excretion alone. So daily iron loss is about 0.5 to 1 milligram in both individuals. Iron, it's lost through the desquamation of epithelial cells, in the urine, you will see, in the sweat glands, in the hairs, in the nails, and mainly through the feces. Now distribution of iron. Iron is present. Distribution of iron in the body is through the hemoglobin that is present in the red cells, myoglobin, heme and non-heme enzymes. The storage form, they are ferritin, hemosiderin. So remember, iron deficiency anemia occur when the supply of iron is insufficient for hemoglobin synthesis. Initially, the body compensates by mobilizing the iron from the tissue stores. So once the stores they get depleted, that lead to iron deficiency anemia. Now what are the factors that contributes to iron deficiency anemia? There could be increased bleeding, that could be from GIT tract, heavy menstruational periods, increased requirement like growth spurt periods, pregnancy, period of rapid growth in the children, or inadequate diet, poor diet lacking in the iron rich foods, or there could be decreased intestine absorption, like diseases like Crohn's disease, celiac disease. That could be the reason. So remember that men, they absorb around 1 milligram per day iron, and women, they absorb around 1.5 milligram. The daily iron, it is absorbed in which state? It's the ferrous state. So this ferrous state, it is converted into ferric state in the body. So the iron binds to the transferrin in the plasma for the transport. The iron, it is transported to bone marrow where it is used for hemoglobin synthesis. So remember, daily requirement for the RBC synthesis, daily requirement is 2400 milligram in males and 1700 milligram in the females. The reticuloendothelial cells, they store around 1000 milligram of iron in the male and 300 milligram in the female. The iron, remember, it is used in the tissue for myoglobin and various enzymes, and it is stored in liver as a ferritin or a complex that is known as ferritin apoferritin complex. Now the excretion of iron loss occur through the skin, GIT tract, etc. Male lose around 1 milligram and female, they lose around 1.6 milligram. The mature red cells, they have a lifespan of 120 days and they are phagocytized by reticuloendothelial cells. The iron from these cells, it is recycled and stored as ferritin hemosiderin complex. Coming to the etiology of iron deficiency anemia, the iron deficiency anemia, it arises from various factors either that increase iron loss, that could be uterine bleeding, like in case of heavy menstruational bleeding during the reproductive years that deplete the iron stores. Young girls may experience heavy bleeding during the onset of puberty. At the onset of menstruational, GIT tract causes could be peptic ulcers. There could be peptic ulcers can bleed and cause chronic blood loss, hemorrhage, hemorrhoids in the rectum. They can lead to bleeding. Apart from that, there could be worms like hookworm, parasites that feed on blood from the intestinal lining. There could be esophageal varices. The swollen veins in the esophagus, they can rupture and bleed. Other could be hiatus hernia. It is the part of stomach that can cause, that pushes into the chest, that can cause bleeding. Apart from that, long-term use of aspirin even can cause GIT bleeding. There could be renal tract cause, like blood in the urine due to various urinary tract infection. The presence of hemoglobin in the urine. There could be nose bleeding. The pulmonary causes could be coughing up of blood from the respiratory tract. There could be growth spurts that require more iron for increased blood volume and muscle mass. Other causes could be pregnancy and lactation. The breastfeeding mothers, they require extra iron to produce milk. Inadequate dietary intake, like due to the poor economic status. Anorexia, reduced appetite can lead to insufficient dietary iron intake. Difficulty in chewing. Like in case of gastrectomy, when the part or all of the stomach has been removed, that reduces the area that is available for the iron absorption. Presence of HCl in the stomach, that would also impair the conversion of iron to its absorbable state. Intestinal diseases, malabsorption diseases like celiac disease, that could be the cause. Now, what would you see? The clinical features would be weakness, fatigue, dyspnea, palpitation, pallor of skin. That you could see is long-standing IDA. It can cause, like the main important is cholynychia. That is, the nails here, they would appear as a spoon-shaped nails. The tongue would be inflamed, and term we use is atrophic glossitis. And there would be shores, mouth shores. The term we use is angular cheilitis. And apart from that, you would see esophageal changes that leads to dysphagia. So these all are feature of Plummer-Vinson syndrome. Now the laboratory findings. First of all, the hemoglobin is the anemia can vary from mild to moderate. So hemoglobin occasionally might be less than 6 gram per deciliter, that could lead to severe blood loss. The red cells in the blood film, they are hypochromic and microcytic, and there is anisocytosis and poikilocytosis. So hypochromia is due to the poor filling of the red blood cells with hemoglobin, so there is increase in the central pallor. So in severe cases, there may be only a thin rim of pink staining at the periphery. Apart from that, you can see is target cells and polychromatic cells. The reticulocytes, they are, remember the reticulocytes, they are either normal or they may be reduced. So the MCV, MCH and MCHC, all they are reduced. The platelet count is usually normal. The total and differential WBC count, they are again normal. Apart from that, you can do is bone marrow finding. The marrow cellularity, it is increased due to there would be the myeloid erythroid ratio that decreases. So here you would see is predominance of small polychromatic normoblast that are known as micronormoblast cells. So these have a thin rim of cytoplasm around the cell and they have a ragged irregular borders. Other cells, myeloid, lymphoid, megakaryocytes, they are normal. So if you do iron staining with the Prussian blue on bone marrow aspirate smear, they show deficient reticuloendothelial cell stores. Apart from that, the biochemical findings that you would see is the serum iron level is low. Normal value is 40 to 140 microgram per deciliter. The total iron binding capacity is high. Remember, in case of chronic anemia, this total iron binding capacity is decreased. The serum ferritin level is low. That indicates that there is indicating poor tissue iron stores. The serum ferritin is raised in iron overload and it is normal in anemia of chronic diseases. Now the treatment of iron deficiency anemia is correcting the disorder that is causing the anemia. You have to identify the cause. You can correct the iron deficiency through iron replacement therapy that can be given orally, or iron IV can be given. Oral iron can be given like ferrous sulfate, ferrous gluconate tablets can be given. Remember, iron should be ideally taken on empty stomach. Apart from that, parenteral iron therapy that can be given when the oral irons, they are poorly tolerated, like in case of GIT side effects, malabsorption syndrome, or when there is severe anemia in the pregnant women. IV or IM injections of iron can be given that include the iron dextran, sodium ferrous sulfate, iron sucrose that can be given. Now the sideroblastic anemia, remember sideroblastic anemia, they are the group of blood disorder that are characterized by presence of ringed sideroblast in the bone marrow. So remember, sideroblastic anemia, these are the nucleoid erythroid precursors with the iron loaded mitochondria arranged in a ring around the nucleus. So sideroblastic anemia, it is characterized by a specific defect in the heme synthesis that lead to accumulation of iron in the mitochondria of the developing red blood cells. So the primary defect lies in the inability to synthesize the heme properly. So remember, here iron, it is entrapped, the iron is transported into the mitochondria as part of heme synthesis. But in sideroblastic anemia, this iron, it accumulates within the mitochondria because it cannot be incorporated into heme molecules. So due to the accumulation of iron, mitochondria appear ring-shaped under microscope. So these are known as ring sideroblast. So the presence of ringed sideroblast indicate that heme synthesis is disrupted. Now what could be the cause of sideroblastic anemia? Remember, it could be congenital, inherited mutations affecting the enzyme involved heme synthesis. Primary cause could be, there could be primary cause, secondary cause due to other conditions like vitamin B6 deficiency, alcoholism, lead poisoning. Based on the clinical symptoms, blood test, you will see these ring sideroblast. Apart from that, you can do is bone marrow examination, giving a vitamin deficiency, addressing the vitamin deficiencies, giving supplements. Now the sideroblastic anemia, it is characterized by impaired heme synthesis that lead to accumulation of iron in mitochondria and formation of these ring sideroblasts. So this condition that results in ineffective erythropoiesis and subsequently it causes anemia despite adequate iron store in the body. Now here you will see siderocytes. So these are the siderocytes. These are mature red blood cells containing granules of non-heme iron. So these will stain with the Prussian blue and we term them as Pappenheim bodies. Now the sideroblasts, these are known as, these are siderocytes. Siderocytes, they are rare in normal peripheral blood, but they can appear after the splenectomy. The sideroblast, remember sideroblast, they are the immature nucleated red blood cells with the siderocytes, that is iron containing granules. There can be normal sideroblast or abnormal sideroblast, or there could be ringed sideroblast having large granules forming a ring around the nucleus due to these iron granules with iron granules. So on what are the laboratory findings in the sideroblastic anemia? First of all, you would see is hypochromic anemia that can be microcytic or normochromic that result in dimorphic blood picture. The MCV, MCH and mean corpuscular hemoglobin concentration, they are reduced. There are raised marrow iron stores, you will see presence of multiple ring sideroblast. The serum ferritin level would increase, serum iron level would be elevated, and there would be increased serum iron binding capacity. So the presence of ring sideroblast. Remember the sideroblast, these are the erythroblast, immature blood cells precursor that are seen in bone marrow with iron loaded mitochondria that you would see under Prussian blue staining. So the iron appears as a ring around the nucleus. So you would see a dimorphic blood picture indicative of microcytic hypochromic cells that indicates iron deficiency, or you can see macrocytic cells which can occur due to the ineffective erythropoiesis. Despite of presence of increased iron stores as seen in serum ferritin and serum iron level, iron cannot be effectively utilized in hemoglobin synthesis due to the heme synthesis defect. So due to this heme synthesis defect, that would lead to ineffective maturation of red blood cells. So from the ineffective maturation of red blood cells, that would result in proper of production of abnormal red blood cells that would not function properly. So you will see Pappenheimer bodies. These are the iron containing granules that would be visible within red blood cells. So the treatment consists of focusing on the offending agent, discontinuing the cause affecting drug. No definitive treatment is required for the heredity, but you can but you can give is vitamin B6. Supportive therapy includes blood transfusion that can be given. The next condition is the anemia of the chronic disorders. So remember, it is also known as anemia of inflammation. So it is seen in patient, it is common type of anemia that is seen in various types of chronic systemic diseases. The underlying cause, so this anemia develops as a secondary consequence of the underlying disease rather than direct damage to the bone marrow. Now, what are the common causes that are associated with anemia of chronic disorders? The first could be infections. The chronic infections, like in case of tuberculosis, HIV, chronic inflammatory diseases, well, that could be rheumatoid arthritis, bowel disease, etc. Malignancies like lymphomas, carcinomas, chronic kidney disease, autoimmune disease like SLE. So these are all associated with acute chronic disorders. Now, despite the presence of adequate iron stores, there is functional defect deficiency where iron is sequestered in the macrophages that occurs due to the increased activity of iron binding protein like lactoferrin. So there could be presence of cytopherins like tumor necrosis factor, interferon, beta, interleukin 1 that are released during this chronic inflammatory state. So these inflammators, remember, these would inhibit the erythropoietin and that would impair the RBC production. So remember, there is an important iron regulatory hormone that increase during inflammation, that is hepcidin. So this hepcidin would inhibit the iron absorption from the intestine and release of iron from the macrophages that would lead to reduced availability of iron for hemoglobin synthesis. Now, chronic diseases, especially the chronic renal diseases, can reduce the lifespan of the circulating RBCs. How? By increasing the destruction. By due to increased destruction, that would reduce their lifespan. Now, what are the laboratory findings that you would see in a acute chronic disorder? First of all, there would be hemoglobin that you can see is mild to moderate anemia. The hemoglobin below 8, that may suggest additional features. On a blood picture, you will see normocytic, normochromic anemia. However, slight microcytosis uh, and hypochromia can be seen. MCHC is slightly low. Reticulocytes, they are low. Apart from that, there would be reduction in erythrocyte lifespan. You would, on the bone marrow examination, you will see the increased iron in macrophages. There would be increased plasma cells in case of chronic infection. The serum iron and total iron binding capacity, they are reduced. Whereas in iron deficiency anemia, you would see the serum iron and total iron binding capacity, they are increased in case of iron deficiency anemia. In the serum ferritin level, it's increased, that indicate that adequate iron stores are there, but there is impaired utilization. Apart from that, you will see gamma globulins, haptoglobins, alpha-1 antitrypsin. These all contributes to increase in the ESR. Now, what would be the treatment? We have to treat the underlying cause, that is inflammatory disease, whether it is an inflammatory disease, autoimmune disease, etc. Apart from that, we can use these erythropoiesis stimulating agents. You can give use iron supplements. Oral or intravenous iron supplements may be considered when there is decrease in the iron deficiency. Blood transfusion may be given. Now, conditions like tuberculosis, lung abscess, osteomyelitis, and pyelonephritis, they all can lead to chronic inflammation that can contribute to anemia. Autoimmune disorders like SLE, they can also lead to chronic inflammation. Other causes could be Crohn's disease, scleroderma. So these all can produce chronic inflammation. Kidney dysfunction can lead to decreased production of erythropoietin and result in anemia. Next, we are going to discuss is hemolytic anemia. So it is a condition there you will see there is accelerated destruction of RBC that lead to their decreased lifespan. So remember, under a normal condition, the RBC, they typically have a lifespan of approximately 120 days, after which they are removed by the reticuloendothelial system, primarily in the spleen. So that process, it is known as extravascular hemolysis. However, in the hemolytic anemia, you will see the rate of RBC destruction will surpass the body ability to produce a new cell, that potentially leading to anemia if the bone marrows, if the bone marrow compensatory production of new RBC is insufficient. Now there are two mechanisms by which the RBC they are prematurely destroyed. One is intravascular hemolysis. So the intravascular hemolysis it occurs when the RBC they are prematurely they occur when the red blood cells they are destroyed within the blood vessels. So RBC rupture in the circulation, releasing hemoglobin directly into the plasma. So excess free hemoglobin it is filtered by the kidneys and it is excreted in the urine, leading to hemoglobinuria that causes a dark color urine. So what could be the cause? There could be mechanical trauma, toxins, severe infections, etc. So what would be the clinical and laboratory findings? First of all, there would be elevated level of free hemoglobin in the plasma, presence of hemoglobin in the urine that results in brown urine. Other symptoms may include jaundice and elevated dehydrogenase. There is a decreased haptoglobin level that binds free hemoglobin. The other process is extravascular hemolysis. So it occurs when the RBC they are phagocytized and destroyed by macrophages, primarily in the spleen, liver and other part of reticuloendothelial system. Now macrophages in the spleen and liver recognize and they engulf damaged or abnormal RBC. The plasma hemoglobin level remain normal because the hemoglobin released from this destroyed RBC it is metabolized within the macrophages. The hemoglobin it's break down into heme and globin. Heme is further degraded into bilirubin, which is then processed by the liver and it is excreted in the bile. So this form of hemolysis it is seen in conditions like hereditary spherocytosis, autoimmune hemolytic anemia. So here you would see increased level of unconjugated bilirubin due to breakdown of hemoglobin. Jaundice would appear, spleen enlargement may be there, and increase in the reticulocytes, that is the immature red blood cells in the blood. It occurs as the bone marrow will compensate for the loss of RBC. Unlike the intravascular hemolysis, there is no significant rise in plasma hemoglobin. Other signs may include anemia, elevated LDH, normal haptoglobin level. Now let us move to the classification of hemolytic anemia. It could be extracorpuscular or intracorpuscular. Now what are the signs and symptoms of hemolytic anemia? One would see pallor in the mucous membrane. It might have a positive family history. There may be mild fluctuating jaundice, dark urine, presence of urobilinogen that increases as a result of RBC breakdown, enlargement of spleen, pigmented gallstone, they may be seen. Now, what are the lab findings? The lab findings you would see is, first of all, there is test that indicates increased RBC breakdown. One is a serum bilirubin, elevated level of unconjugated bilirubin, urine urobilinogen, increased level without bilirubin urea, fecal stercobilinogen, so that the level would increase due to that would indicate the increased breakdown of RBC. The serum heptoglobin level it would reduce as it bind to free hemoglobin released during the RBC destruction. The plasma lactate dehydrogenase level they would increase, indicating the increase in the cell turnover. So what would be the evidence of intravascular hemolysis? Presence of hemoglobinemia, hemoglobinuria, methemoglobinemia, and hemosideриnuria that would indicate. Other test is to test that indicate increase red cell production. So in order in the body's response to increase RBC destruction would be increase red cell production. So here the test you would see is reticulocyte count, that would increase. You will see on a blood picture, you will see is on a blood picture you will see macrocytosis, polychromasia, and presence of normoblast. Now the test that indicates damage to red cells could be osmotic fragility test. So this test would measure RBC resistance to hemolysis in hypotonic solution. Other test is a Coombs antiglobin test. It will detect antibodies or complement bound to RBC surface. Other test would be hemoglobin electrophoresis that would identify the abnormal hemoglobin. Other test would be test for the sickle cell, identifying the sickling of RBC, screening for glucose 6-phosphate deficiency that includes the presence of Heme bodies. Now the test that can be done to determine the shortened RBC lifespan is 51 chromium labeling method. So here this test involves labeling the RBC with the radioactive chromium and tracking their survival rate. So their normal lifespan, that is of about 120 days, is greatly reduced. Now let us discuss about the classification of hemolytic anemia. We discussed that it can be classified as extracorpuscle and hereditary, that is intracorpuscular type. The acquired hemolytic anemia, that is extracorpuscular. So these anemia result from external factors affecting the red blood cells. Antibody mediated immunohemolytic anemia, that could be warm antibody autoimmune hemolytic anemia, that is caused by IgG antibodies that react at body temperature. RBC, they are destroyed primarily in the spleen. Other is cold antibody autoimmune hemolytic anemia, that is caused by IgM antibody that react at cooler temperature. So RBC, they are destroyed in the liver and in the bloodstream. Other could be drug induced immunohemolytic anemia. Certain drugs can induce the immune system to attack the RBC. Other causes could be mechanical trauma like microangiopathic hemolytic anemia. Here the RBC, they are physically damaged as they pass through the small abnormal blood vessels. The example could be DIC. Conditions like disseminated intravascular coagulation and thrombocytopenic purpura, it falls under these conditions. Infections like malaria, bacterial sepsis can directly damage the RBC. Acquired red cell membrane can be paroxysmal nocturnal hemoglobinuria. So it is a rare condition where RBC, they are abnormally sensitive to complement that can lead to intravascular hemolysis. Second type is hereditary hemolytic anemia, that is intracorpuscular. So these anemia are due to the intrinsic defect within the RBC themselves. That could be hereditary spherocytosis due to defect in the protein that maintain the RBC membrane shape, that leads to spherical RBC that are more prone to destruction. Other could be hereditary ovalocytosis, hereditary stomatocytosis. Here the RBC have a mouth-like appearance. Second can be disorders of red cell interior. Example could be hexose monophosphate shunt defect, glucose 6-phosphate deficiency, a glycolytic pathway defect, pyruvate kinase deficiency. Structural abnormality hemoglobin could be sickle cell anemia. Here the abnormal hemoglobin causes RBC to become sickle shaped under stress, leading to hemolysis. Now the extracorpuscular hemolytic anemia caused by external factors, that could be antibiotic, mechanical trauma, direct toxic effect, splenomegaly. The first example is autoimmune hemolytic anemia. So the warm antibody autoimmune hemolytic anemia, the autoantibodies, they react at body temperature, and usually it's the IgG type. Whereas in cold antibody autoimmune hemolytic anemia, autoantibodies that better react at cold temperature, usually at 4 degrees Celsius, and it consists of typically IgM type. Other can be drug induced. Drug-induced occur when medication trigger the immune system to attack the RBC.